In this session, we are going to discuss about the disorders of visual interpretation, particularly those of higher cortical function as related to vision. So, disorders of visual interpretation can be classified as illusion, hallucination, and disorders of higher cortical function. Illusion occurs when there is a visual stimulus in the visual environment, but the subject interprets the stimulus erroneously. So illusions disappear with eyelid closure when the subject no longer sees the visual stimulus. Hallucinations occur in the absence of a visual stimulus. Even in the absence of a visual stimulus, the subject has a perception of vision, and so it usually does not disappear with eyelid closure. Hallucinations in the presence of visual impairment are release phenomena and are not due to neuropsychiatric disorders. So, for example, a patient has severe loss of vision from bilateral optic neuropathy. Then, activity in the visual cortex can result in hallucinations in the subject. Entoptic phenomena must be differentiated from illusions and hallucinations, and they occur due to particulate objects inside the eye and in front of the photoreceptors, such as floaters, which is a very common complaint which we face in the clinic. So these disorders may be present even when the patient has a normal visual acuity and color vision. Illusions can be due to optical causes, retinal causes, optic nerve causes, or cortical causes. In optical causes of illusions arise from abnormalities in the tear film, as in dry eye, corneal abnormalities as in keratoconus, iridotomies, and cataract. Pseudophakic patients may perceive a negative or a positive dysphotopsia, which is an arc of a shadow or light in the temporal field. Illusions from retinal causes result from metamorphopsia, that is distortion of the image of an object, micropsia, that is an object appearing smaller than it really is, or macropsia, and these result from pathologies like epiretinal membrane, macular hole, macular edema, and subretinal pathology. So when the photoreceptors are separated from each other, there will be micropsia, and when the photoreceptors are crowded with each other, there will be macropsia. Intake of certain drugs may cause an altered color perception, such as with digoxin causing a yellowish discoloration and sildenafil causing a bluish discoloration. In retinal and choroidal ischemia, there can be persistent after image of a bright object. So when the patient is seeing a bright object and the bright object is suddenly removed from the visual field, the patient perceives a persistent image of that bright object. Following demyelinating diseases such as optic neuritis, there may be an unilateral conduction delay for a prolonged period of time, and this unilateral conduction delay result in Pulfrich phenomena. In the Pulfrich phenomena, a pendulum oscillating in a frontal vertical plane appears to oscillate in a three-dimensional elliptical path. So if there is a delayed conduction in this eye and normal conduction in the optic nerve of this eye, the pendulum appears to rotate in an elliptical path in this direction. Occipital lobe lesions may distort the interpretation of the visual characteristics of a stimulus in the visual environment, such as size, shape, color, position, and movement. And parietal lobe lesions may result in micropsia, macropsia, telopsia, that is stimulus appearing further than it really is, pelopsia, a stimulus appearing nearer than it is, and polyopia. So hallucinations can be formed or unformed. In unformed hallucinations, the patient perceives dots and geometrical patterns. But in formed visual hallucinations, the subject actually perceives images of objects, although those objects are not there in the visual field. So posterior vitreous detachment and retinal detachment can cause flashes or photopsias, and these are momentary. And outer retinal lesions such as multiple evanescent white dot syndrome, acute zonal outer ocal retinopathy, and cancer associated retinopathy, they cause photopsias or flashes which are continuous. So these are momentary flashes and these are continuous flashes. In optic neuritis, there may be flashes with eye movement, and long-standing optic neuropathy can cause perception of light with a loud noise, and this is called a sound-induced photism. Among cortical causes of visual hallucination, we have palinopsia, that is perseveration or persistence of an after image of a visual stimulus even after that visual stimulus is removed from the visual space. And it can occur in lesions of parietal, temporal and occipital lobes in both the dominant and the non-dominant hemispheres. So we have an illusory palinopsia and we have an hallucinatory palinopsia. In illusory palinopsia, the after image is perceived in the same location as the original stimulus, as this short clip shows. So we have an after image here which appears in the same location as the original image. It can occur in migraine and also with certain drugs like LSD, topiramate and clomiphene, and it is induced by contrast and or motion of the original visual stimulus as we see in this clip. And in hallucinatory palinopsia, the image is perceived at a location different from the original object, and this may happen with posterior cortical lobe lesions which result in homonymous hemianopia with an after image in the blind hemifield. Visual snow, also called static or dots, is a perception of mobile dots brighter or darker than the background in both the eyes, affecting the entire or part of the visual field. And these dots, unlike floaters, do not clump or change in size and shape. And they persist for months or years. They do not affect vision and they are associated with migraine but not exclusively. So if we see this clip, we see these small dots which appear mobile. Hallucinations can occur with migraine and is very well known as aura, also known as decopsia or a scintillating scotoma with fortification spectrum. This typically occurs in the homonymous hemifield contralateral to the occipital lobe affected with migraine, and it starts as a small scotoma surrounded by a zigzag colored or a silvery edge, which then spreads to the periphery, then breaks up and finally disappears. And it is variously described as a cracked glass or a kaleidoscopic vision. It lasts 5 to 60 minutes, followed by a hemicranial headache which is usually contralateral to the aura. Other visual hallucinations which can happen with migraine are snow, which we have seen in the previous slide, or Alice in Wonderland phenomena, in which there are a variety of visual distortions. Hallucinations can occur with sleep disorders, and they are very vivid in nature, appearing as images of persons and animals, and they can occur at sleep onset when they are called hypnagogic hallucination, and when they occur at awakening from sleep they are called hypnopompic hallucination. So we come to a very important syndrome called Charles-Bonnet syndrome, which should be differentiated from another syndrome which we will come to in a later slide called Anton syndrome. So Charles-Bonnet syndrome is a form of release hallucination from a deafferented cortex. So the visual cortex no longer receives sensory stimulus from the afferent pathway. Thus it occurs in visually impaired individuals like age-related macular degeneration, glaucoma, diabetic retinopathy, or even cerebral infarction. And the visual hallucination can be formed or unformed, and formed visual hallucinations in Charles-Bonnet syndrome can be either simple or very complex, and the hallucinations may be intermittent or persistent. What is most important is the patient is psychologically aware that he or she is hallucinating and that his or her vision is severely impaired. Treatment is difficult apart from reassurance. Hallucinations can also occur from other brain lesions, usually caused by seizure activity, from neoplasia, malformation or ischemia. So occipital lobe seizures usually cause unformed visual hallucinations. Parietal lobe seizures usually cause formed or unformed visual hallucinations. Temporal lobe seizures usually cause formed visual hallucinations. And even midbrain and pons lesions can cause visual hallucinations, in which case it is called a peduncular hallucinosis. Peduncular hallucinosis is a vivid hallucination and it is associated with inverted sleep-wake cycle. Alzheimer's and Parkinson's diseases or levodopa treatment in Parkinson's disease can also cause formed visual hallucination. So coming to the third part, that is disorders of higher cortical function, and this can be due to stroke, tumor or degenerative disorders such as Alzheimer and Creutzfeldt-Jakob disease. The functional disorders can be categorized as disorders of recognition, disorders of visuospatial relationships, and disorders of awareness. Awareness both of vision or awareness of visual deficit. Disorders of recognition can be of various types. In object agnosia, the patient cannot identify an object visually. However, the patient can identify an object by touch. And this occurs in bilateral ventral occipitotemporal pathway, the what pathway. Prosopagnosia is an inability to recognize familiar faces, and it occurs also with a bilateral inferior occipitotemporal lobe damage. It can also occur with only a right inferior occipital lobe damage, in which case it is associated with a left superior homonymous hemianopia. In cerebral achromatopsia, there is an abnormality in the color discrimination, and objects appear washed out in color, and it can be due to bilateral or unilateral occipitotemporal pathway, the what pathway, or inferior occipital damage. So we can have complete achromatopsia or we can have hemi-achromatopsia, and there can be difficulty in perception of only one primary color or all colors. And in cerebral achromatopsia, visual acuity contrast sensitivity can be normal and there may not be object agnosia. Akinetopsia is an abnormality of visual perception of motion, and it occurs with damage to the dorsal occipitoparietal pathway or the where pathway. Alexia is a difficulty to read written language, and it may be associated with agraphia, that is a difficulty to write, or it may occur without agraphia. So damage to the splenium of the corpus callosum or the right occipital lobe cause alexia in the left visual field, because the pathway from the right occipital lobe to the language center passes through the splenium. Damage to the left occipital lobe results in alexia in both the visual fields. A left occipital lobe causes alexia in the right visual field as well as from the left visual field, because it interrupts the pathway from the right occipital lobe to the language center. In an isolated occipital lobe lesion, the left angular gyrus is intact and it can still produce language both in the written form or in the oral form. Interestingly, the patient cannot read what he has just written. That is because the intact left angular gyrus produces the written language, but the interruption here from the visual cortex to the language center makes the patient unable to read what he has just written. And if the lesion is here in the left angular gyrus, the patient has difficulty both in interpretation and in production of the language. So the patient has both difficulty to read and difficulty to write. Other symptoms of left parietal lobe dysfunction may also occur, and this cluster of symptoms is called Gerstmann syndrome, and it includes acalculia, that is inability to do mathematical calculation, finger agnosia, that is inability to count or identify fingers, and right-left confusion. Visuo-auditory reconciliation disorder occurring lesions in midbrain tectum, and the perceived auditory stimulus from a perceived visual stimulus is not accurately projected to the perceived visual stimulus. Coming to disorders of visuospatial relationship, simultanagnosia is an inability to integrate parts of a visual scene into a complete whole. So these plates are commonly used to diagnose simultanagnosia, and patient sees parts of the picture individually but cannot integrate the whole. So the patient may see the boy falling, the girl pointing upward, or the mother washing, but cannot integrate the entire picture. And in this situation, the patient may identify the individual letters but may not interpret the big letter constituted by the smaller individual letters. And simultanagnosia occurs for parietal lobe lesions, and these patients may also fail Ishihara plates despite normal color vision, because the Ishihara plates consist of numerous dots and the patient needs to integrate those dots visually so that he can identify the number in the plate. And visual alesthesia is a perception of the visual environment being rotated, flipped or inverted, and it occurs in lateral medullary syndromes and in occipitoparietal lesions. Balint syndrome results from bilateral occipitoparietal lesion, and it consists of a triad of simultanagnosia, optic ataxia, and acquired oculomotor apraxia. However, the three parts of the triad rarely occur together to form the complete Balint syndrome. In optic ataxia, the patient has difficulty to perform visually guided tasks, so he may be unable to reach or point at an object seen, though he is able to reach or point at an object or a sound which he hears. And in acquired oculomotor apraxia, the patient has an inability to shift gaze towards a target of interest. Coming to disorders of awareness of vision or awareness of visual defect, we have Anton syndrome, which we must differentiate from Charles-Bonnet syndrome. And in Anton syndrome, there is denial of blindness. In Charles-Bonnet syndrome, the patient realizes that he or she has blindness. And in Anton syndrome, there is denial of blindness along with hallucinations and confabulations. And this usually occurs in bilateral occipital lobe damage, but may also occur in patients with bilateral optic nerve damage. And in blindsight, there is an unconscious rudimentary visual perception. So there is a visual perception, but the patient is not aware of that visual perception, and this happens with bilateral occipital damage. And this explains why a blind patient may be able to avoid obstacles. And this unconscious visual perception is said to involve optic tract projections to superior colliculus and pulvinar, and not to primary visual cortex through the lateral geniculate nucleus. In Riddoch phenomena, which usually occurs in the blind hemifield of a patient with homonymous hemianopia, the patient may not be able to detect a static object in the blind hemifield, but may be able to detect a moving object in the blind hemifield, and this is also called staticokinetic dissociation. And Riddoch phenomena may actually portend a better visual prognosis for the patient. Hemi-spatial neglect occurs with lesions in the right cerebral hemisphere, so the neglect usually occurs in the left hemifield. And in these patients, when simultaneously presented with similar visual stimuli in the right and left hemifields, they ignore the object in the left hemifield. However, when presented with the stimulus in the left hemifield only, the patient is able to detect it. These patients also have difficulty in clock drawing test and in bisecting horizontal lines. In clock drawing test, the patient is asked to draw the hours of a clock and to represent a mentioned time, and the patient may draw one side of the clock and not draw the other side. And when asked to bisect horizontal lines drawn on a paper, the patient may not be able to bisect them accurately. Thank you for listening.